how we have to make a life of a type 1 very, very normal. So pump plays a very important role there. So just to introduce you to insulin pump is a device which is used to deliver insulin subcutaneously, just like the insulin pen. The meal bolus insulin can be delivered via pump to provide insulin to compensate for the carb intake and also for the hyperglycemic episodes. And the basal insulin in the pump, the basal insulin is a continuous rapid acting insulin. In this, we only use rapid acting insulin, which is given in a continuous flow in the as a basal insulin in a pre-programmed manner, which is according to the metabolic needs of the person. So basically, insulin pump helps to provide flexibility, it improves control, it decreases instances of hypoglycemia. But while we're talking about insulin pump therapy, it is very important for us to select the right candidate for insulin pump. So as we go ahead, we will talk about candidates, we'll talk about what are insulin pump in detail and what is the pump that is being used these days. So what is an insulin pump? A small computerized battery operated device. In the pump that is being used these days, which is 780G, a AA battery is used. It allows the user to control exactly how much insulin is delivered. So it is a very precise device. What are the components? It has an insulin reservoir in which we can store up to 2 to 3 days of insulin, and it is very heat resistant, so the insulin doesn't go bad in it. It has a thin plastic tube called the infusion set. You can see it in the image here. It has a soft cannula or a needle which goes inside the skin, which actually delivers the insulin in the subcutaneous tissue. How does it work? Insulin passes from the reservoir pump through the tubing into the subcutaneous tissue. And the best thing about insulin pump is that it tries to closely mimic the normal pancreatic insulin delivery. So when we talk about the normal pancreatic insulin delivery, how does the normal pancreas work? First of all, the normal pancreas deliver insulin in the portal way, not in the subcutaneous. And it happens in two phases. So when we are fasting, the pancreas release insulin at a very low rate, okay, just to manage the hepatic glucose production. But when we eat, the pancreas release insulin very, very rapidly to manage all the spikes, right? And to uptake the glucose and suppress the glucose production from the liver. So this is the figure which tells you how the pancreas works. So this is the basal insulin, and this is how when we eat food, the insulin is released from the pancreas. So is there a similarity between insulin pumps and the normal pancreas? Yes. So while we spoke about the delivery of the basal rates, it is pre-programmed. The delivery of a constant background rate of insulin, which is called the basal rate, it is pre-programmed as per the need of the individual, right? And there is bolus delivery. This delivery of the dose, which is the insulin bolus dose, meets the requirement of the food intake. It is calculated according to the carbohydrate intake of each meal. And it can also correct any high blood glucose readings as a correction dose. So in the insulin pump, we can program multiple basal rates. So as this is the one benefit of an insulin pump. When we give insulin through pens and syringes, there is basal rates which can maximum be adjusted. Like we can give a different basal rate in the night and in the morning. That's the maximum we can do. But in the pump, we can give nearly 48 different basal rates. And the basal rates can be adjusted to the metabolic need of the patient. So we will see that many times people need less insulin in the night, but as the morning is there, like between 4 and 7 a.m., people need more insulin. Then during the day, people need less insulin. And then again, after dinner, sometimes people get sedentary, they need more insulin. So depends upon how your routine is, people basal rate requirement changes. So we can change it according to the need of the patient. When are actually pumps advised? Pumps are advised when there is suboptimal control, when there are huge excursions of sugar, when there are frequent hospitalizations of diabetes because of diabetes ketoacidosis, when there is nocturnal hypoglycemia or there is hypoglycemia unawareness, when there is intense activity or varied activities. So pump comes very, very useful. When there is dawn phenomena, remember we've already spoken about dawn phenomena in the morning also, when the requirement of insulin between 4 a.m. and 7 a.m. is high. When there is gastroporosis, in the gastroporosis, there is delayed digestion. So sometimes we need extended release of insulin. So in pump, there is a feature via which we can give extended release of insulin when we are planning conception, because we really need strict control of sugar. When there is different school schedules and type 1 really struggle with injecting insulin in the school, and there is a lot of insulin resistance in type 2 diabetes. And who should give the pump and who should initiate the pump? The pump is not necessary. The pump can be initiated only by a certified diabetes educator or a certified pump trainer. And these are the requirements. When you initiate the pump, these requirements, these detailed records should be in front of you. A CGMS or detailed blood glucose records, an AGP graph, what are the insulin dosages, when does the patient eat, what is the physical activity, does stress really affect the patient's sugars, premenstrual, postmenstrual, all these readings are very important when you are starting the insulin pump for the patient. Now, there are 5 settings in insulin pump which you have to be really, really aware about. There is the active insulin type, there is the target range, basal rate, insulin sensitivity factor, and insulin to carb ratio. And this is the sign of the setting in the new pump. We'll talk about these 5 settings. First of all, what is active insulin? Active insulin is basically the insulin which is there from the previous bolus. And it is very important to know, and you can see in the image how the active insulin is shown in the pump. It is showing 0.3 unit. It means how much insulin is still there from the previous bolus, which can still work and bring the sugar down. So pump normally, when it decides how much insulin has to be given, it subtracts the active insulin and then only calculates the bolus dose. Even while giving a correction bolus, it will subtract the active insulin, right? So it prevents stacking of insulin. So it prevents you taking more insulin. This happens only if you're using a bolus wizard, which is a feature in insulin pump, or you're using the latest pumps, which are the 780G. The other feature is which you have to know is the insulin to carbohydrate ratio. It's a very simple thing. People get confused, but it's a very simple thing. It is just that how many grams of carbs are covered by 1 unit of insulin. This is required because on the basis of this calculation only, a bolus dose is calculated. Okay? The purpose is to determine the number of units needed for food bolus. And the goal is to provide the right amount of insulin which will bring down the sugars post meals. So how do we calculate this? The calculation is 500 rule. We take the total daily dose, which is the basal plus the bolus, and then we divide it by 500. 500 number, many people ask me, how has it come? It has come because it's an estimate of how much carbohydrate a person can take and how much the glucose has come from the liver. So it's an approximation. So of the total number of carbohydrate person can eat in the day and how much carbohydrate liver produces. So it's a sum total of that divided by the pump total daily dose. So if you can see in the slide, so I have said that, okay, if a person is taking 50 units per day, you divide 50, you divide 50 and 500 and you get 10 grams of insulin to carb ratio, which means 1 unit will cover 10 grams of carbs. But how do we test that whether we have calculated the insulin to carb ratio correctly or not? So for that, we need some time with the patient. we will have to collect some data from the patient. We will have to collect the fastings, the pre-meal sugars, the 2-hour post sugars. We will have to collect how much insulin the patient is taking for each meal, how much carbohydrate the patient is consuming each meal. And the best way is to make a carbohydrate consistent diet for the patient when you are doing this. Because if the patient is eating different amount of carbohydrates different days in different meals, it will be very difficult. So calculate the amount of carbohydrates you want to eat or give the patient in each meal and try and give options according to that. Make sure the patient logs in every food and every beverage that the person is eating, even if he's eating a lot of protein and fat, because definitely fat and protein also affects the blood sugar. Then you will be able to calculate the carbs and see how much insulin is required throughout the day and for each meal, and then you will be able to test the insulin to carb ratio. But what if we have to adjust it? Because for the same person, different meals, ICR requirements can be different. A person may be more sensitive to insulin in the evening because the person has exercised, but may require more insulin for the morning time. Because sometimes even in type 2 diabetes, the fasting is high and the post breakfast is very high. Even in type 1 diabetes, the fasting sometimes are not manageable and the post breakfast comes high, right? So different ICRs may be required for different needs. So how do we do this adjusting bit? So for adjusting, we have to check 2-hour post meals after each meal. And the goal is that after a meal, the blood sugar should be increased by 30 milligram to 60 milligram. Then the ICR is okay. If the blood sugar is not over 140, ratio is correct. If 2-hour post-meal blood sugar has increased less than 30, so which means your post-meal blood sugar has not increased much from the pre-meal, which means you're giving too much insulin. So we increase the ICR. So remember, higher the carb ratio, less bolus for the same amount of carb. This becomes a little confusing. That's why I've simplified here. So if the post-meal has not increased much, then too much insulin. So you increase the ICR, which means higher the carb ratio, less bolus for the same amount of carb. If 2-hour post-meal blood sugar has increased more than 60 milligram per dl from the pre-meal, you are not giving enough insulin. So you decrease the ICR, which means lower the carb ratio, more bolus for the same amount of carb. And patients may have the same ratio of insulin to carb throughout the day or 2 to 3 different ratios during the day. So ICR ratios can be confusing. So always remember to decrease bolus amounts, increase the ratio. To increase the bolus amounts, decrease the ratio. Remember this formula always. Now there's another another setting that we talked about, which is the insulin sensitivity factor. So for that, we use the rule of 1700. 1700 divided by the total daily dose, which means that 1 unit of insulin will lower the blood glucose to what number? Okay, so that is called the correction factor or the insulin sensitivity factor. Now, why do we calculate all this? We calculate all this because all of this has to be fed in the pump. So how do we start a pump actually? It's a very simple process. That is how we do it till now also. So if the existing total insulin dose of a patient is 50 units, we reduce the dose by 20%. If the patients, normally we start the pump only if the patient's A1C, first we try and bring it below 8. If the patient's HbA1c is above 8, we try and bring it in control so that we get a good total daily dose. So if the existing total insulin dose is 50 units, we reduce the total daily dose by 20%, right? Then we have to split that dose in twos so that 50% of it is bolus and 50% of it is basal. Then for the basal, 20 units, for example, in this example, 20 units per day, we set a flat rate for 24 hours. and the other 40 we divided in 3 meals as bolus doses. So it's a very simple way of doing it. You take the total daily dose, you reduce it by 20%. If the HbA1c is in target, then you divide the dose in two parts. So half of it is basal, half of it is bolus. You divide the bolus in three and you divide the basal by 24 to give a flat rate for the first few days. And then you adjust the basal according to the need of the person. So as I was saying that then initially we may take a flat rate and then we adjust according to the patient's need. The second thought is also that we can adjust the basal rate according to the circadian rhythm of the body, which I was initially also talking, that patients may need in the early hours of the night, may need less insulin, in the early morning may need more basal rate, during the day may need less basal rates, and again sometimes may need more basal in the evening. So depending upon the person's metabolic rate, metabolic needs, you can then change the basal rates, and this is more closer to the circadian rhythm. So then we have this feature called the bolus wizard, which is again very important. So for the bolus wizard to work, we have to put in the insulin sensitivity factor, the insulin to carb ratio in this, and it will calculate the active insulin on its own. The most important thing with the bolus wizard is that it makes this pump very smart, so that you will get a calculated bolus for each meal of yours. So for this, the patient checks the blood sugar, it manually types the blood sugar into the pump, right? And patient just enters the grams of carbs the patient is eating. So you have already fed the insulin to carb ratio, the insulin sensitivity factor. The pump has calculated and given you the units that will be used. And that's how the patient is calculated. We've already talked about the ICR. We have already talked the insulin sensitivity factor. The bolus wizard subtracts the active insulin from the total units that have come in and then tells you how much bolus to inject. So now what we're going to talk about is the kind of pump we are using now. From the Minimed paradigm pump, which was launched in 2006, now we are using the advanced hybrid closed loop pump, which is very close to what we may call something which works totally like pancreas, which is based on smart guard technology and automation, right? So what is this advanced hybrid closed loop technology? And how is it help in overcoming the patient's challenging in managing their diabetes? Even if the patient was on pump, you understand these are all the actions the patient has to take, has to check the blood sugar, has to correct and correctly calculate the bolus, deliver the bolus in the night, in the day, each time the patient is eating food, bedtime, to understand the dawn phenomena. So many times throughout the day, the patient is struggling. So you understand that even if a patient is on pump, though we are saying that it is increasing the flexibility, giving you convenience, still the patient's life is not that easy. That is why automation was required. And remember, with even a very strict regime, fixed routine, patient's blood sugar is like a thumbprint, different every single day. Every night is different, every day is different, because there's so many factors which actually affect the blood glucose levels. So initially I talked about the challenges of patient selection. We have to select the correct patient. So we have been talking about insulin pump, and you've seen how much calculations are needed. So initially we used to say there are ideal patients for insulin pump who can count carbs well, who can adhere to diabetes management, are technically very capable. But what are the kind of patients we actually get? Patients do not consistently count carbs. They struggle with technology sometimes. They have to incorporate diabetes management in their day-to-day tasks, and sometimes it gets difficult from there. And it takes time for them to adjust to insulin therapy. But what if we change the whole pyramid? What if we change the whole paradigm of what kind of patients are good? What if we just say that we talk about the new typical patients and we talk about less suitable patients, right? This is the benefit of Minimed 780G system overview. We can give it to more number of patients because it is more patient centric. It's more helpful to the patient. So what is in this is that the center is the insulin pump. It is connected to Guardian Link 4 transmitter. Guardian Link 4 transmitter now is used. Initially it was Guardian Link 3 transmitter. Now they are both connected, right, through Bluetooth. This transmitter is communicating with the pump. The pump is communicating with the MiniMed mobile smart app. All of this data is going to the CareLink server, and there all the care partners can actually access all the data that is available. So who can use this pump? For the management, and what are the studies saying? For the management of type 1 DM in the persons requiring insulin, you can use this pump. For anybody whose age is 7 years and older. So for 7 years, we are also using this pump in patients below 7 years. Those studies are not there, but we're still using it. So in type 1 patients, 8 units to 250 units per day. So when we talk about 8 units, the smart guard technology will only get activated when the 3 days average of the total daily dose is 8 units, right? It's not that one day. 3 days average has to be minimum 8 units of insulin. It is not still studied in pregnant women or person with type 2 diabetes or person with anti-hyperglycemic therapies who do not include insulin, but still many people with type 2 diabetes are also using it. Every patient has to start on 780G with a manual mode, regardless of any previous pump or CCMN experience. Because for 48 hours, this pump will work on manual mode. It has to get adjusted to the body. It requires at least 48 hours of insulin delivery data before the smart guard technology kicks in. Okay. And in these 48 hours also, it has these two features, which is it will get suspended if your sugars fall below, and it will even preempt that your sugars are about to fall low and can get suspended. So these two features get automatically on, even in the manual mode. So what is auto basal? Basal insulin delivered every 5 minutes based on the sensor glucose readings. As I said, there's a sensor, the transmitter is continuously communicating with the insulin pump. So after every 5 minutes, the basal gets delivered according to the sensor glucose readings. It studies, the smart guard studies how the sugar is rapidly increasing, decreasing, or what is the trend, and accordingly will deliver the basal insulin. And it aims to keep the patient between 70 to 80 milligram per DL to maximize the time in range. And whatever basal insulin readings you had set in the manual mode, it has nothing to do with this once the smart guard takes over, right? The default target is 100, but the options are 100, 110, and 120. So I'll repeat, the basal insulin is delivered every 5 minutes. So every 5 minutes, the sensor is communicating, the readings are being checked, the patterns are being checked, it is preempting, it is adjusting, and according to the sensor glucose, the basal insulin is being delivered. So if you see this graph, the upper line is a sensor glucose reading, and the line below in pink is the auto basal. So you can see that there are auto basals wherein the sugars are going up, there is auto basal, and then suddenly it gets suspended also. So automatically, if the pump gets a signal that the sugars are about to fall or are falling, the basal is totally suspended. So there is a maximal basal rate which it can go up to, and then the basal rate gets suspended. The maximal basal rate is nearly 200% of what you had set. Once it gives the maximal basal rate, then only it will give you a bolus correction dose. So this is how the auto basal works. How does the auto correction works? How does the bolus gets delivered? Bolus gets delivered automatically if the algorithm of the smart guard technology determines it is needed, right? So only if the algorithm sees that even after giving the maximal basal dose, the sugars are not coming in target, then only an autocorrection dose is given. Correct? So autocorrection bolus occurs when maximal autobasal delivery is reached. So as I said, when the 200% of your basal is maximized, then the bolus will be given as a correction dose. And the default mode, the autocorrection is on. The correction target is normally set at 120 milligram per DL. It uses the sensor glucose readings and it can be delivered every 5 minutes. And active insulin, if it is there from autocorrections, it will be subtracted. So in this figure, you see the purple, the pink is the basal and the blue is the bolus. So every time the basal has maximized, it is only after maximizing the bolus, you can see a basal shot being given. Okay, so basal insulin adjusts every 5 minutes, giving based on the sensor glucose values. And then the autocorrection target is set at 120 and autocorrection is only delivered every 5 minutes if max basal is reached and the sensor glucose is still above 120. If you have set your pump on temp target, which can be set for 30 minutes to good number of 8 hours, then there will be no autocorrection. How do we do the onboarding? We do all these calculations for the insulin to carb ratio, for the sensitivity factor, for blood glucose targets, for active insulin time in 780G is normally set for 2 hours. For adolescent children, it is set for 2 to 3 hours. We normally reduce the total daily dose by 15 to 20%. And for setting the basal insulin dose, the total daily dose is multiplied by 0.5. If the half dose is less than 0.4 units per kg, we use the weight to understand how much insulin has to be used, and then basal insulin into 24 hourly base rate. The right arrow here is a shortcut to understand the time in range, which is a very important feature for seeing how your patient is doing. We just click on that arrow, we get a time in range, we scroll down, we see more information to understand how much is above, how much is below. Make sure that your patients understand that everything is not fully automated. The patient still has to put in effort. The patient has to enter the carbs, the bolus before eating, has to enter the blood sugar readings. If the patient is on G3 only, calibration is only required every 12 hours if the patient is using Guardian Link 3 sensor. If the patient is on Guardian Link 4, then calibration is not required. The patient has to set up the CareLink account. Basically, the care partners have to set up the CareLink account. For patients, it is the MiniMed mobile app for automatic uploads on their phone. And sometimes, if the sensor does not get readings for a certain number of hours, then we have to follow the SmartGuard instructions, right? It might ask for a blood sugar, and we have to follow whatever the SmartGuard feature is telling us to do, because it might again go back into a manual mode. So basically what we are trying to tell here is that automation of insulin delivery has made the life of people with type 1 diabetes and whosoever is using the 780G pump a little easier, because it has brought improvement in glycemic control, reduction in hypoglycemia, and reduction in diabetes management burden. So thank you, and our status is totally done. I am open for questions if there are any.